Welcome to Global Diabetes Insights, your go-to podcast for navigating the world of diabetes. I am Tino, a certified diabetes educator and a global advocate for non-communicable diseases.
And I'm Kona, a global advocate and a medical doctor. Together, we're your hosts, dedicated to raising awareness, fostering open discussions, and creating a safe space for everyone affected by diabetes.
Join us as we dive into empowering conversations with individuals living with diabetes, caregivers, healthcare professionals, and researchers. Our goal is to not only guide you through effective diabetes management, but also to inspire advocacy for proper healthcare access.
So get ready for a journey of insights, ideas, and diverse perspectives. Let's amplify our collective voice and create positive change. Get involved, get engaged, and join us in creating the change we need. So welcome everybody to Global Diabetes Insights.
Right. So greetings to you, Shannon and Belinda. Thank you so much for honoring our invite and for being here. So maybe I'll just kind of ask you both to introduce yourselves.
Thanks for having us, Tino. My name is Belinda. I'm based in Victoria, Australia. My professional background is a registered nurse-midwife and credentialed diabetes educator. I currently work in the Aboriginal and Torres Strait Islander community in my town. And in that town, I work in two capacities. So I work as a credentialed diabetes educator, also as an antenatal and postnatal midwife, and also work on the FLASH glucose study, which is a 6-month randomized controlled trial for the Aboriginal and Torres Strait Islander people living with type 2 diabetes.
Thank you, Belinda, and for the invitation. And thank you, Tino. My name is Shannon. Initially, when I started working in diabetes, I started working in the culturally and linguistically diverse community in Australia. Myself is the first generation of the immigrants from China, working with those immigrant communities and refugees are something really close to my heart. So I started working as a dietitian and also later a credentialed diabetes educator. But now I'm actually carrying a few hats. So I'm working as a diabetes course director at one of the universities in Australia in Sydney. But at the same time, I also doing some of the outreach clinics in the indigenous community in New South Wales in Australia. And at the same time, I also working as a diabetes education and training specialist for Life for a Child, the international type 1 diabetes organization. So it has been my privilege to be here and chat with both of you.
Thank you so much both for your amazing introduction. So I guess we are going to touch on various topics, which is great because we want to inspire our listeners so that they can know that they can do so many things. Maybe we'll start with Belinda. It's always great to start off with from you, Belinda. Maybe if you can take us through your journey in terms of how you came about working in the field of diabetes in pediatrics and pregnancy.
I actually have a sibling with type 1 diabetes. He's had it for about 34 years, so diagnosed in 1989. Back in Australia in 1989, that's when we used to draw up insulin from the glass ampules, and he had to mix it himself. And that actually in itself is quite a reason to do what I do in the advocacy space, because whilst Australia has come a long way from when he was diagnosed and mixing up insulin and still using insulin syringes, now we have insulin pens and pumps and CGM devices. There are so many countries that are still doing what we did back in 1989. Anyway, I won't get too focused on that. A lot of people think I came into diabetes because of my brother, but actually that's got nothing to do with it. He lives his own life and he's quite self-determined with his own diabetes, keeps it pretty simple. Initially, I came into diabetes when I was working up in the Kimberley. The Kimberley is a region up in the top of Western Australia. It's outback Australia. It's predominantly where a lot of Aboriginal and Torres Strait Islanders live. Back in 2007, that's when I worked there initially. Again, it's quite sad to think that back in 2007, when I was second year out of nursing college, when I was working there, I wasn't a midwife, I wasn't a diabetes educator, I was a brand new nurse that knew nothing. The outcomes back then compared to the outcomes now for the Aboriginal and Torres Strait Islander communities are worse. They're worse now. So it's quite sad to think that our outcomes for Aboriginal and Torres Strait Islander people with diabetes have gotten worse since 2007. So that constantly motivated me to not only work in the field of diabetes, but when I was out in the Kimberley. I also had to catch my first baby. And again, as I said, I wasn't a midwife. Done a 3-day birthing in the bush course to prepare me for just in case sort of scenarios. It was in the middle of the night. It was myself and a enrolled nurse, so a nurse that's done a little less training than myself. So between the two of us, we sort of figured it out. But after that experience, I walked away from the Kimberley and came back to my home state, Victoria, which is on the opposite side of the country, very determined to upskill in 3 areas: pediatrics, midwifery, and then diabetes education. So I started my pediatric training at the Royal Children's Hospital in Melbourne. Interestingly, I just fell into the diabetes side of pediatrics in the emergency department, and then I moved on to working as a midwife. And so when I started doing my midwifery training, not a lot of midwives will take on the portfolio of wanting to support women with diabetes. There's quite a fear amongst midwives about diabetes. I think the fear, well, there's no research, but they're certainly deserving of doing more research to understand why midwives don't want to work in the field of diabetes. I think there's a fear of diabetes complicates pregnancies, and so then they're not going to be able to practice midwifery in the really simple home birth models of care or the low risk models of care. But again, my argument is that us midwives who specialise in diabetes, we actually have the power and the knowledge in both fields of midwifery and diabetes, so we can actually help women who have diabetes experience as much of a midwifery model of care, because we can actually try and normalise complex or the high risk pregnancies.
Thank you so much for sharing that with us. I also may want to hear this from Shannon as well, why she's doing what she's doing. I know you're from a developed country, but your focus seems to be to help people in the developing countries. So many people, like healthcare professionals, really, if they get the opportunity to be in Australia, they will leave, no questions asked. If they are just asked, would you want to come and work in Australia? People just go. So maybe we would want to know, like, from your journey, like, what have you learned over the years? Because you're someone who's working and trying to upskill people from the developing countries. Would want to know.
I actually coming from a different perspective. I actually was born in China, which is developing country, and I actually from kind of rural, not really remote, but rural sort of city in China. So we're not well. So diabetes is very prevalent in China. I think the prevalency is actually around 13 to 15% for diabetes, and China is one of the largest countries to have the number of the people living with diabetes. So diabetes is very close to my heart. It affected many of my loved ones. So that's how I very determined when I came to Australia, when I actually finished my university study for dietetics and nutrition, I was determined to specialize in diabetes. That's where I was coming from. I'm living in a pre-diabetes, and I knew that long time ago because of family history. So that's how my heart goes to those, and in particular, those vulnerable communities in Australia. That's how I started in the immigrants and refugee community as my first job in diabetes. So I'll be supporting the first diabetes prevention program for the Chinese immigrants. And then I further expanded to looking the whole CALD, which we call them culturally and linguistically diverse communities in Australia. From the Diabetes New South Wales and Diabetes Australia perspective, leading some of the national program for those communities as well. Because of that, my heart goes to my country and my people. I also further actually did my PhD in those sort of CALD topics to hope to actually make a difference to those who are actually living with diabetes but coming from a non-English speaking countries or immigrants or refugees. So that's how I actually started in diabetes, expanded my passion in diabetes.
This is interesting.
Just to divert, I think there's a misperception that in Australia we are incredibly lucky compared to many countries in regards to access to diabetes care and education and technology and research, etc., etc. But I think there's a misconception that everyone in Australia has it easy. And unfortunately, particularly in the current times, the health disparities in our country enormous. The expression of the rich are getting richer and the poor are getting poorer era is very, very relevant to those experiencing diabetes. And we see it across the globe. Sociocultural determinants of health are just not being recognised, even in places like Australia. And because of that, those that just don't have access to housing, education, income, the healthcare system are suffering. And diabetes is one of those leading conditions that's so prevalent in a lot of our culturally and linguistically diverse communities. I come from a town here in Shepparton, which is northern Victoria, which is predominantly either Aboriginal and Torres Strait Islanders or culturally and linguistically diverse communities. I'm actually the minority and I'm born in Australia. So that's how diverse Shepparton in North Victoria is. It's very similar to the Western Corridor of Sydney, which is near where Shannon is based. We very much, particularly in the context of Aboriginal and Torres Strait Islanders in Australia, we have third world conditions in a first world country.
People from the developing countries, this is our perception really. We say maybe people in the developed countries, they have it better. Everything is just handed to them. They don't have to, speaking about the insulin for all those kind of things. We don't know. People don't really understand if there are inequalities too that exist in people from these developed countries. So this is great, really. So, and I believe this podcast will serve also just to spread awareness to say, hey, people, if you want to move, say you want to move to developed countries, you need to consider things like this if you won't be affected, especially if you're a person living with diabetes, because it's not always cream and butter, right? So thank you so much for sharing that perspective with us, Belinda, and jumping in to collaborate with what Shannon was just saying. I think maybe a bit of a follow-up to Shannon's contribution. Shannon, as a person who is working with diverse diabetes communities or doing so many things, speaking on conferences, if you could highlight maybe a few key learnings from your field, from your journey on the things that you've been doing, working with diverse diabetes communities, maybe would be a little bit interested to learn from that.
Thank you for that question. And I really like the background that Belinda just put it in. And Indigenous Australian or Aboriginal and Torres Strait communities in Australia sometimes, to many ways, I really think they're a bit like immigrants or refugees. They're really vulnerable. Only going to share three things I really think it's really important for us to know as a health professionals. And the first is actually empathy. The second is to be inclusive. And then the third is actually collaboration. So that's three of the key things I always remind myself. And when I'm actually talking to other health professionals or peers, that's the things I actually share with them. And just coming back to the first thing I like to share, I think it's very important for us to be empathetic to those vulnerable communities or people, such as people from refugees, immigrants, or Indigenous Aboriginal Torres Strait Islander peoples, and acknowledging their cultural and linguistic and social economic factors and how those factors all together affecting those individuals. Just because they're living with so many different barriers or factors affecting their diabetes, those factors really shaping, their view about diabetes and their ways of self-manage as well. And we all understand as a health professionals, diabetes, there's no one-size-fits-all approach. It's all person-centered care. So it is vital for us to understand where they're coming from, so we'll be able to tailor our education and support to be able to actually suit for those diverse needs, especially those have a diverse cultural backgrounds or the language needs from the mainstream of Australia. So this is critical for us to think about which approach do we go for diabetes education or diabetes management, and that holds a key for our effective management for diabetes as well. And the second is that it's so important for us to be inclusive and open to different views and cultures, and recognizing individuals may have a diverse belief, traditions and practice, especially the Aboriginal Torres Strait Islander community I'll be working with, or the immigrant communities. They always have different food cultures, traditions. Our Indigenous community eat a lot of game meat like kangaroos. They have a lot of bush fruits that we don't normally have in the Western diet. Talking about immigrants, we're all eating different staple food. We're using different cooking sort of herbs and spices. It is important for us to embracing that. That also holds a key for us to establish the trust and rapport with those individuals as well. And sometimes I have to see it's not necessary every time I actually have the same view or the culture when I actually looking at the clients living with diabetes, especially from the clients from Aboriginal and Torres Strait Islander communities. They have a different view, but the best I can do is actually embrace them, being inclusive myself. So I think that's a really essential approach for our diabetes education, to respect and align the cultural values and norms and fostering the sense of cultural safety to ensure the information or the education we provide is culturally relevant and safe and accessible to them as well. And I think the last one is collaboration. We all know that working in healthcare, we have to working as a team. The collaboration here, I specifically want to emphasize on the teamwork with the cultural brokers. Dealing with immigrants and refugees, we're talking about bilingual, cultural, social workers and translator interpreters. But within the Aboriginal and Torres Strait Islander community, they're also social workers, and they speak so many different languages just like us, like immigrants. So they are translators for some of the community, especially those in Northern Territory or Western Australia. And also, most importantly, working with Aboriginal health workers who actually really help us to bridge the gaps in terms of cultural difference and languages as well. And they really helps us to facilitate really effective communications, understanding, and also engagement in diabetes. So the collaboration, the efforts we put into collaboration really enhance the quality of our diabetes education and also the impacts we're making to care for them as well. It also guiding us to providing a culturally appropriate and comprehensible sort of diabetes care to individuals. So these three key things, empathy, being inclusive, and collaboration, I think are the three of the most important things for us as a health professionals working with Aboriginal Torres Strait Islander peoples as well as immigrants and refugees for their overall well-being.
This is interesting as it gets. I cannot thank you enough for sharing that with us. We always say diabetes is not a one-size-fits-all. We need to understand what is the issue, what is the problem, what is the challenge, and then how can we tackle it. Diabetes, yes, we know that it's the same, but our approaches should be different. We need to understand the culture itself, what type of food these people are eating, and where they're getting it from. It is so great to collaborate, to work with so many people so that we can tackle the issue that is on the ground, or should we say the elephant in the room. So thank you so much. Belinda, maybe as someone you're determined enough to help improve the clinical diabetes outcomes, like I just wanted to know, maybe the audience would also want to know, like, what do you wish we knew? How can we come up together to create the change that this community or this world needs?
That's a really great segue from what Shannon was just saying. I'll give you one example which supports all that really important theory that Shannon was just saying, and then I'll describe a little project that I'm working on to take that further. A couple of weeks ago, I was looking after an Aboriginal elder with type 2 diabetes. I was helping them with continuous glucose monitoring sensor, just to highlight how you actually put that empathy into practice, particularly in the Aboriginal culture, but I don't think it is just relevant to the Aboriginal culture. I think you have to do this with any diabetes community. You just need to give people the space to get their words out and tell their story, particularly those from Aboriginal and Torres Strait Islander community, the culturalistically diverse communities. There's a history there that's often traumatic and often confronting, and that's often a big part of the trigger towards experiencing chronic health. When I acknowledge the wrongdoings of colonisation with this elder and his son, I could just see their shoulders just drop and relax. I didn't say anything. I just let them speak and I just listened. I gave them that safe space for them to talk, and then that takes that empathy to trust. And with the Aboriginal and Torres Strait Islander community in particular, because we have the unfortunate wrongdoings of colonisation before Shannon and I were born, before any of us were born on this podcast, that is incredibly important, because if you don't acknowledge those wrongdoings, they're just going to look at us as Europeans or Westerners or white fellas and relate that back to those wrongdoings at the time of colonisation. What I wish more people knew, in answer to your question, is I could probably rephrase that. What I wish more people would do is respectfully challenge the status quo. a lot of health professionals working in the diabetes space, particularly diabetes educators and endocrinologists and general practitioners, primary care, GPs, are just so swamped with the workload. But the problem is that everyone just keeps working faster and faster, and they keep complaining that they're busy. And it's actually, do you know what? We actually have to step back away from that and stop being so busy so that we can actually recognize how we need to do things differently. We can't actually keep going at the pace we're going because we're not effective. I think a lot of campaigns at the moment are trying to, we need to increase the annual cycles of care. We need to increase the number of HbA1c, increase the number of eye screening. It goes much deeper than that. We actually need, in the context of Aboriginal and Torres Strait Islanders, but also the immigrant and refugee community, we actually need to understand how people use the healthcare system in their past communities or in the Aboriginal and Torres Strait Islander context pre-colonisation. So a project that I'm just about to get off the ground, and I'm very, very excited. I know Shannon knows about it. Came back from one of our conferences in Adelaide recently, a little bit inspired, wrote down a proposal in my phone, as you do. Every day I go to work and I run diabetes consults and I hand out diabetes fact sheets, and you go through blood sugar books and you go through pump downloads and CGM downloads. And it's a bit meaningless to the Aboriginal and Torres Strait Islander community I work with, which is not similar to a lot of communities that a lot of other CDEs work with. And it's just like, how do we actually give that power back to community to educate themselves, but also educate their community? I'm very much a big fan of leading from the back. What I'm going to be doing is over a 6-month period with the elders, so the older people in the Aboriginal and Torres Strait community, is actually meeting with them monthly, and I'm going to bring back traditional painting and storytelling, or yarning is what we call it in the Aboriginal community. I'll meet with them monthly and I'll get them to paint where they're at as an individual with their diabetes. So I want them to paint from an Aboriginal perspective what their diabetes at the current time or at that current month means to them. And then before I walk away from that monthly catch-up, I'll just say, okay, change one thing in your life, but that's as prescriptive as I'm going to be. That's up to them what they want to do. And then second month, third month, 4 month, we'll continue that painting, and they'll continue to paint where they're at with their own diabetes, and they'll tell their story when we catch up each month. So then at the end of the 6 months, they'll actually each have a 6-month mural that will actually be like a trajectory of their diabetes experience. And it will be really interesting to see how does this actually empower their own internal beliefs, internal ways of doing things, so that they can actually change things that they see needing to be changed, rather than us as health professionals saying you need to go and carbohydrates out, or you need to go do more exercise, or you need to go lose weight, or whatever. It's actually putting the power back into their hands so that they can identify what does or doesn't need to be tweaked in their lives. Also educating the children about living with chronic health, living with diabetes, maybe what they did or didn't do. The little children will also maybe take that away, and we'll send them away each month and say, okay, go away and maybe change something for you and your family. And then we'll do that every month as well. So what we'll be also doing at the beginning and the end of the 6 months is actually doing some yarning groups, getting the elders to do 3 sort of yarning sessions focused on what does diabetes and mental health mean to you. And then we'll do it at the end to see if their beliefs have changed as well. If that pilot program works, that's how we'll be running diabetes education for our Aboriginal and Torres Strait Islander community, because, as I said, challenge the status quo. I think that's what I wish everyone did more of.
I just want to jump in, Belinda. Yeah. I think what a brilliant program it is. I think that's such a great integration of getting the cultural and traditions of the Aboriginal and Torres Strait Islander people using, the ways that they feel culturally safe to deliver diabetes education, and really empowering them, and also looking at intergenerational sort of method of passing down those experience and those diabetes learning to the younger generation as well. And I also like to reiterate here to your audience, Tino, the indigenous Aboriginal Torres Strait Islander concept of health here is actually different from the Western concept of health, which we emphasize a lot on the individual, the physical or the mental health of an individual. But to many of my people coming from China, immigrant backgrounds, or your people, health is actually much broader concept. It really deep interconnect with many of the components rather than the individual themselves. So it is physical and emotional health, certainly, but kinships, families, land, communities, and the spiritual part of that are also important in their definition of health. They're all interconnected to each other. So it's many components actually building up to their concept of health. So that's how I really like the creativities of Belinda's program, not only emphasize on the physical health, which we could actually set up so many surrogate markers to looking at CGM, blood glucose testing result, and etc. But they're also looking at the family, intergeneration education, looking at kinships, looking at, some of the cultural activities, and painting is one of the symbolic sort of ways the indigenous community actually practice and express their views and thoughts into painting as well. I think for that program, it is so great to see how they actually align the Western diabetes education approach to tailor to the individual indigenous concept of health, align with their perspective of health as well. In that, we're not only addressing the clinical needs of diabetes, but also considering the social and emotional aspects of their health as well. Thumbs up to you, Belinda. It's such a great program, and I wish you all the best, and I'm sure it will be a successful one.
That's exactly why we need to challenge the status quo. Currently in Australia, we have the parliamentary inquiry into diabetes. That's only just closed the submissions, I think, August the 31st. That's going to take a couple of years to go through. I think currently there's almost 500 submissions from all sorts of people in Australia, diabetes organisations, advocates, people with diabetes, family members of diabetes, individual health professionals. We can't wait for that to come up with a solution. We can't wait for the government to say, we're going to give some funding to do this, that, or that. Currently, we have a Western model of care in a non-Western community, whether it's the Aboriginal and Torres Strait Islander or the culturally and linguistically diverse communities. We need to challenge the status quo, design the models of care that are going to work for them.
I have no words. We need to get involved, because it doesn't mean that the government, if they're empowered, they're going to use their time to change these things. We need to take it up to them to say, hey, we are going to do this. So let's get engaged together and collaborate so that people can have a greater future in this world that you're living in. So thank you so much both for all that is you do.
The program that we're doing, it's actually costing less. So it's not costing the government anymore, because we're using the resources and the tools that are already in community. Currently, if they want to come and see a diabetes educator or a dietitian, it comes under the EPC funding or, whatever funding there is in that primary care clinic. But we're actually using 2 activities officers in the elders facility, 2 health promotion officers, that this is their bread and butter of their job, a child health coordinator, also her bread and butter of her job, and an oral health manager. And I'm just there to enjoy. And lead from the back and guide, but basically enjoy and just watch that power be handed back to them. But I think it also just highlights that there's resources there that are not being used because we've gone to this Western model of care that, knows better.
To be more relevant to your audience back low resource countries, I think the model why Belinda and I chose in the Aboriginal Torres Strait Islander community and all culturally and linguistically diverse community, because they are really vulnerable communities in developed countries, and in a way they may be more relevant to your audience. And the examples how Belinda actually created and developed her program can be examples to your audience as well, if they are health professionals. And resources for health resources for indigenous and immigrant, they're really limited. And in the outreach or remote clinics, and both Belinda and myself actually are running, we don't have everything. They may just get diabetes educated. They don't even have specialists. They have family doctors, but they don't have other allied health supporting them. So we have to trying to do the best we can. And one of the other skills we're having is actually knowing where to find resources ourselves. So we're multi-skilled. We're not only trained as a diabetes educator or midwives or dietitian, but we kind of trained as a social worker to fulfilling the gaps. Many times I'm supporting the family doctors to do healthcare forms and filling the government document, paperwork, housing, finding a housing, those kind of social work sort of jobs to do. So that's how we're addressing the social determinants of health in those communities. Or back in your country, like the villages, you're probably one of the most knowledgeable professionals about diabetes, even though they may not have doctors. So you're trying to fulfilling the gaps at the best you can, to trying to actually empower and support our people at the best of our abilities. So that's how, in a way, we're living in different countries, different circumstances, but we're all sharing the same passions, and we're all supporting those vulnerable individuals. So there's no boundary to any of us here.
I think I like both your clinical approaches on how you do things, tailoring your approaches in what works for the people that you're working in where they're coming from. You go there not for them to come to you, maybe because it might be difficult. Rarely you'd see people going to see their doctor because they say, hey, it might be expensive, you need to pay for consultation. These things might not really be applicable. Things that are being used by people from the developed nations might not be applicable to those that are used, especially for the Aboriginal. Still using those rock paintings, and you still have to use how best can we help you? What is it that she wants us to do? Leading from behind, trying to understand their cultural background. They'll take you and would welcome you, so that there is a balance between the two. So thank you so much for your approaches and your passion, which goes beyond. I hope that everybody else would be inspired with this. I think, Shannon, already you a bit touched on these. Maybe we would want to know, like, if you could take us through, like, how you do your indigenous outreach clinics. We used it to a tradition where people have to go to a clinic, people have to go to a hospital, but your approach is just something else. You do outreaches.
Certainly, I'm happy to talk you through how we do it, but I think I work same as Belinda, Aboriginal Medical Service in the remote or rural area in Australia, in particular in my state, New South Wales. So my role is as a diabetes educator and also dietitian, as you could actually guessing from my title, lead the diabetes clinics, provide the critical diabetes and nutrition education to our clients. The diabetes clinic sits within the Aboriginal Medical Service. It's a comprehensive sort of medical service that we offering to the indigenous community in that local area. So we have quite a few specialized clinics. We have, most of the time, we have dental, eyes, women's health. Sometimes we may have cardiology or pain, or sometimes we may have exercise physiologists there to supporting us as well. So those specialized clinics, we're all working together. That's coming back to one of my key learning a little bit earlier. It's about collaboration. So we're all working as a team. So together we're addressing different health needs and providing a holistic approach to healthcare to our clients, and which to them, diabetes, it's only a small part of their health. So we're trying to address everything in their definition of health, which social cultural determinant of health, it's really a key thing holding their health. I have introduced a little bit earlier about their concept of health, which probably have more cultural element and spiritual element into that as well. When we're actually doing outreach, some of the clinics we may have on site, some of them we don't. So one of the things I actually, every time when I'm doing a new clinic, is actually learning where the health resources are. Like, Tino, when you're doing your services back in your country, you just have to know who you can help with, because they're quite isolated. Even though we're in Australia, developed countries, some of our clients in 10 years of living with diabetes, they never actually seen a specialist. All they have is family doctors in remote or rural cities or towns that I be visiting. Seeing a GP or family doctor sometimes takes months to get in. So it's not like a privilege. We got free access of healthcare. There are, like Belinda said earlier, disparities in Australia, especially for those vulnerable communities. That's why both of us are very passionate, doing our best to supporting them. We coordinate, collaborate with local or state national services, trying to providing the holistic health approach as the best of our abilities. One thing I also teaching our newer diabetes educator, one of their formal assessment is for them to identify some of the local health services in their area so they be able to provide holistic care. I believe being inclusive, knowing, being able to work in a multidisciplinary team, it's really a key for diabetes educator or any of the health professionals working with those communities. That's why I emphasize a lot on those aspects as well. Apart from providing diabetes and nutrition education, my role a lot of time involves supporting our family doctors in coordinating relevant cares for our clients. That's including even assisting them with appointment schedule. We don't have all the health services locally for our clients. We have to send them to somewhere to the specialist in the metropolitan areas, transfer their care notes to specialists whenever needed, or hospital is part of our role as well. Working with housing or welfare community, the community services or health workers are also part of our role, and which is critical because that's really addressing the social determinants of health. My role is really diverse, and it's not only clinical, just in diabetes and nutrition, but well beyond that, at a broader sort of skill sets we need to have and enable for us to addressing the social determinants of health more effectively to actually ultimately improving the overall health outcome of our client. I guess that's probably a snapshot of how I'm providing the outreach clinics. It's not everything I'd be able to do it, but it's about working as a team and collaborating, reaching out, coordinating the care.
I don't know, Belinda, would you have anything to add to that? Wow, this is amazing.
I think we can all get overwhelmed. Even just to quote my idol, Brené Brown, massive fan of Brené Brown, I think we tend to label experienced healthcare professionals as experts. We tend to label people with diabetes as experts. And then that can be very overwhelming for communities that are either vulnerable, like the Aboriginal and Torres Strait Islander communities, the culturally and linguistically diverse communities, low socioeconomic countries that have very low resources in diabetes care and education. Like I know, Tino, yourself, heading off to ISPAD, and there's been a lot of other people with diabetes head off to various conferences, EASD, IDF, ADA. One day we'll get people down to ADC here in Australia. We need DDOC here in Australia as well. I think it can be very overwhelming for those of you who hear the experiences of high resource countries and hear from those of us who are health professionals with what seems like everything at our fingertips. But as Brené Brown says, we really need to avoid the word expert because it's a very end point sort of a word. It's like, well, that's it. Nowhere to go. And I think we need to avoid that. And like Shannon was alluding to, and even in our previous little discussion prior to that, we need to really just actually step back and look at our own little worlds and build up our own individual and community capability and capacity and just do what we can, because otherwise we sort of, particularly the low income countries, you're sort of striving for the stars, which is not your context. Like context is everything. So if we just, really internalize back to our own contextual settings, my setting is very different to Shannon's setting. The Aboriginal community 1.5 hours down the road from me in another town is very different again. We know that Aboriginal and Torres Strait Islander communities, and there's hundreds of them around Australia, are not homogenous. And that's the same as culturally and linguistically diverse communities. They are just so contextually diverse and different. So we just have to lean into our own resources and build up that local capability and capacity.
Thumbs up to you both, Shannon and Belinda. So I believe by the way you're working and the things that you're doing, you're also inspiring people that you work together with, because the energy itself that you have to do all these things is amazing. And we appreciate that for whatever that is you do. In most cases, especially people from the developing nations. Let's say, for example, you've been diagnosed, and for you to go back to see a doctor again, you're living in the less remote areas or in the villages, and if you have gotten sick, that's when you'll be sent to a hospital, not for reviews. That thing doesn't exist here. It's seen as a luxury. And because they know each and every time that you have to go see a doctor, it'll be pumping on. It's not that it's much. I don't know why you think that, or why that approach, or why people have that kind of a perspective. And we should not go like for 5 months without seeing our healthcare professionals. We should have conversations. Speaking not only because you need help, you need to be hospitalized, but in most cases, people go back to the hospital when they need to be hospitalized after diagnosis. You see people saying, it's been 5 years since I last saw a doctor. I only saw a doctor when I was diagnosed. So I'm here just taking my insulin, the same doses, everything about it. but you're eating a lot, you've never seen a dietitian, you've never seen a diabetes educator, you've never read anything about diabetes after your diagnosis. So what you know is that I have diabetes, I need to be injecting, which at times people, they might even skip, they might even ration dosages because it's a bit expensive. If they are supposed to inject themselves like twice a day, they would end up injecting maybe say once. I think this is something that we also need to change. Why do people have to take the medication that they should take? Why should people go back to see the doctors? The healthcare professionals, they are not our enemies, right? They want to help you. Maybe their approach is what would push people backwards to say, hey, you don't need to come here. Because sometimes people would see like healthcare professionals might be a bit judgmental. You're doing it wrong. You shouldn't have done what you've been doing. You don't have to do this. So people really don't see the motivation. They don't see the motivation to see a doctor. Nothing is being appreciated.
That's a beautiful segue into the power of peer support. That's why we need to bridge the gap for a number of reasons. I mean, as Manny Hernandez, I think it is, from the peer support community. Where's he from? He's from Latin America, I think. And Renza Shibilia, who also quotes Manny's slide. You've got the blue circle, and then there's a tiny little sliver that's missing. That tiny little sliver is equal to how often people see a health professional. The rest of the circle, they're on their own. And that's exactly why, which is what you're saying, Tino, we have to fill those gaps with peer support. And that's not because services are not meeting the needs, or, we don't have enough professionals, or we don't have enough funding. No matter how good the healthcare system is, or the diabetes system is, or how many health professionals you have, doesn't matter what country you're in, what language you speak, us as health professionals need to link people with diabetes into other people with diabetes. And there's lots of different ways to do that. Like when I worked with the ENDIA study, which is a nationwide study happening in Australia, I used to just have a yarn with the pregnant women in the waiting room. And if I saw another pregnant woman who I knew had type 1 diabetes, I would say to one woman, hey, do you want to meet someone else with diabetes? I never got a no. Even the shy women who's like, oh, yeah, maybe, I would actually just bring them together and just start the conversation to break the ice. And then before you know it, they're best buddies, because they've got that connection. Like, it's really not hard. We just need to, I think health professionals can get really formal and really technical. And it's like, let's just bring the humanistic element back into what we do as diabetes professionals. There's all sorts of online peer support platforms now. Doesn't matter, as I said, it doesn't matter what country you're in. If you've got a device, internet, that's really all you need.
I think, Tino, you have done a great job in that space, supporting, people in your country as well, doing peer support. And we really admire your job. I think when you ask, what's my wish list, Belinda and I, we're all passionate about building up the healthcare workforce and its capacities. But one of my wish lists for that capacity building is really community engagement and empowerment as well. Having community-led diabetes education program, like a peer support program in any shape or way, really ensure that engagement and relevance is within the community and client themselves. So you're actually really supporting them by empowering them, giving them accountabilities and ownership as well. So they're more engaged in their diabetes, and diabetes management make more sense to them because it's applicable, it's relevant. It also supports their concept of health. I think that's one of the vital part of diabetes management. It's a diabetes management doesn't really necessarily to be done by healthcare professionals, community leaders and peer support leaders. They are part of the connection. They are part of this whole picture of diabetes as well. No matter where you go, which country you are in, whether you have a lot of resources or not, they are the same thing. People all need that community engagement and empowerment.
It means a lot. It means a lot. Everything that is you're doing.